thank you for the LSRS for the opportunity. So by way of disclosure, I've actually never implanted an interspinous device, but I've had a lot of experience removing them. So, but we'll try to keep an open mind. The purpose of this is education, and I think trying to understand what the role these devices play. So I think we're about half the room, this poster, nobody knows what this is, but this is a classic Clint Eastwood movie. So the good, the bad, the ugly, right? That's what kind of comes to mind when I think of interspinous devices. So first, I think we'll cover the rationale for design. So why would this seem like a good idea? Because obviously someone thought it was a good idea when they designed these devices. So we'll delve into that. And then we'll also look at some of the pertinent literature around these devices. So, the big question, why an interspinous device? So we're seeking alternatives to an open laminectomy. So if you look at some of the earlier devices, this is probably, at the time, the only alternative you had was an traditional open laminectomy where you're removing the spinous process. I think, when tubular laminectomies and discectomies were probably, coming to the fore around the same time of the development of some of these products. So initially, we're primarily looking at treating lumbar stenosis. And at the time, it was thought it could be a potentially less invasive procedure. So again, for half the people in the room who don't remember, weren't around for this, but I remember, just doing a one-level laminectomy open. It's a big incision, a lot of blood loss. You're putting a drain in. That's a fairly morbid procedure. Not very many people do that anymore. You have more evolved techniques with using a tube or an endoscope. But again, this is kind of the environment where these types of initial devices were conceived in. And then another important distinction is between the class of devices. So you have the interspinous distraction devices, and then you have the interspinous stabilizers. So the distraction devices are probably the older designs. Pretty much everyone's heard of an X-stop. The other product that people know will be familiar with is Vertiflex, which is made by Superion. Superion, which is made by Vertiflex. And then you have some of the more modern designs, the interspinous stabilizers. So Coflex is probably something that's familiar to most folks in the room nowadays. So a bit of history. So the first FDA-approved interspinous device was the X-stop. This was back in 2005. And most people, when they think of X-stop, you think of Kyphon and Medtronic, but it was actually St. Francis Medical that got the original FDA approval. So this is all public domain. If you do a Google search on any product that's been approved by the FDA, you'll see this letter. And so the interesting thing is just to look at the indications for use. So 1 or 2 level for patients with lumbar stenosis. They don't mention spondylolisthesis in here, but essentially you're doing this instead of doing a laminectomy. So that's the idea with these devices. So this device, you can't get an X-stop anymore. It was taken off the market, and a lot of it was because of fractures after they were implanted. So what happened? So at least in terms of the principles of treatment, they sound, there is some rationale to this. So you want to decompress the central canal and foramen by preventing lordosis, preventing distraction of the posterior elements. And there's some MRI and cadaveric data that shows a reduction in cross-sectional area in the spinal canal in extension. So when you see a patient with neurogenic claudication, what do they do to help alleviate their symptoms, right? They flex forward. So essentially, when you're putting an interspinous device, you are permanently fixing someone in that posture to help with their lumbar stenosis symptoms. So essentially, the idea here is to achieve an indirect decompression without jeopardizing spinal stability at the instrumented level. At least that's the idea. But this is where things start to go wrong, right? And so what exactly happened here? So when you look at the biomechanical analyses as the rationale for these devices, so the idea is that by putting an interspinous device, you can increase the cross-sectional area of the dural sac and of the intervertebral foramen. So here you can see on these CT images, before and after you putting in the device, the canal expands, the foramen is larger, and so that, again, that's the rationale. So, but there is some conflicting evidence about the treatment durability. So you have a few studies that show an increase in this area at 1 week postoperatively, but then you see no differences at 3 months. Other studies will do something similar, and they'll show a significant increase in the dural sac cross-sectional area up to 1 year after surgery. So there's a bit of a conflict in the data. I think probably the article that's been cited a lot to refute these claims is this study out of Sweden. And you keep in mind, in Sweden, they don't really like to fuse people, right? Because they feel like a laminectomy is superior to a fusion for spondylolisthesis. So this particular study did MRIs under axial load. And they basically wanted to put to test the claim whether or not the canal was actually larger with the interspinous device under axial load. And essentially they found after 3 months there was no difference. So basically you were the same 3 months after surgery with the device with an MRI under axial load as you were beforehand. And in addition with the axial load MRI, you actually saw significantly reduced the canal size in the adjacent operated levels. So you're actually diffusing the problem into the adjacent levels. And here's an example from the paper. You can see, preoperatively on the left side, that's an axial, that's a cross-sectional image there, an axial view on T2. On the right side, this is the same patient post-operatively. This is an axial MRI, and you can see there's really no discernible difference in the canal size after the interspinous device. And so, and with that coupled with the changes you see in the adjacent segments, really you start questioning whether or not these distraction devices are efficacious. And then what about fractures and migration? So I don't know if any of you have ever been to this site. This is from the FDA, the Manufacturing User Facility Device Experience. So any device that's approved in the FDA, if there's an adverse event that's reported, you can look it up here. So you can look up the TOPS device. One day, we'll see who wins the debate. You could look up arthroplasty that Jad mentioned. You can also look up your interbody cages. If you're using 3D printed titanium, anything that you're using, you can look this up. So what's notable with the X-Stop device is they had quite a bit of device fractures, and that caused Medtronic to pull it off the market. So that's round one. So looking at the inner device, the distraction devices. Go next. So what about the stabilizers, the interspinous stabilizing devices? So here, this is the approval letter for Coflex. So the one thing I want to point out, it's a little bit different in terms of the indications for use here. So whereas X-Stop was meant to be used standalone, you'll see here that the Coflex is meant to be performed in conjunction with a decompression. So we've kind of moved the goalposts a little bit in terms of what we want this device to achieve. And then here's a couple studies that I wanted to go over. First, this is a randomized prospective trial looking at, this is out of Germany, where they compared a decompression alone with a decompression with an interspinous stabilizing device. And then here's a second study. This is a 5-year outcome study. This wasn't randomized, but also a comparison between the two techniques over 5 years. So the second paper I referenced, this is the Kumar et al. This is the 5-year data. So they looked retrospectively, 116 patients. 61 patients received the decompression with the interspinous device. 55 received decompression alone. They used kind of the usual patient-reported outcome measures for their outcome. And they saw significant improvements in the patient-reported outcomes from pre to post-operative within both the interspinous, with and without the interspinous device. They didn't see any differences between the improvements in ODI, EQ5D, SF36, and the leg pain scores between the groups, but the back pain favored the interspinous group. And then when you look at radiographically, they did see preserved better foraminal measurements in the interspinous group compared to the direct decompression. So the other study, Schmidt et al. With the prospective randomized study, but this is only 2 years of follow-up, they randomized 110 patients to the decompression with the interspinous device and 115 with the decompression alone. So similar to the, what Mike presented earlier, this is a kind of FDA-style comparison where you have a composite success where it's basically all or nothing. And they found that they had better outcomes in their decompression plus interspinous device. Now, the interesting thing is one of the reasons, one of the criteria they placed for what would be considered not a success if a patient had to have some sort of injection into their spine post-operatively. And really that was the biggest driver between the differences in the two groups, is that the patients who received decompression alone versus the interspinous group, they had a higher rate of injections. So, you know, is the conclusion that we should be putting Coflex in for all of our lumbar decompression patients? So one thing that is a little bit unclear is how is the differences in the decompression performed. In the 5-year study where they didn't really see a difference, they were very explicit in how they did laminectomy. So essentially it was the same operation. They preserved the spinous process. They did bilateral laminotomies. But in the randomized paper, they didn't really talk about how the laminectomy is done. So whether or not this was done traditionally where you're taking down the spinous process, whether or not it's done minimally invasively or not, that's not clear. And then really the question is how does this technique compare to more modern ways of decompressing the spine, either a tubular or endoscopic laminectomy? And then finally, I think the important question is, all these devices come at an increased cost, right? And so really does the difference that we see in outcome, does that justify the cost of the device and potential for a new set of complications that you introduce by putting in a device, right? So, so that's all I got. Thank you.